Welcome to the Reverse Mullet Healthcare Podcast from BP2 Health. Today, we are in Mainline Studios in Westchester, Pennsylvania, talking with Dr. Dan Elliott, Chief Medical Officer at Delaware First Health, about the dire need for the rational use of data, including the ruthless elimination of fancy. But first, who are we? Why are we here? Why are we the Reverse Mullet?
Oh, you're looking at your new mug? You're very excited by this.
I am.
Yeah,
very excited
much
about
so.
it.
Why did we name it the Reverse Mullet?
Why?
Well, we want to be relevant, informative, and creative, but you also want to be entertaining and have fun. So it's a party in the front and business in the back, like a mullet, only reversed.
We are your hosts, Ellen Brown.
Justin Politi.
Dave Pavlik.
We are passionate, innovative, and collaborative, and are committed to solving our industry's most important issues together with our clients. We have, the three of us, a combined 90 years of experience.
It makes us sound so old.
And when we add Dan to the mix, what do we got?
120 probably, right?
Hard to believe.
In each episode, we will dig into a hot healthcare topic and dig into each other.
We do not dig in to our guests, at least not too much.
And you have to be gentle on me.
No chance.
No chance, not at all.
So we are super excited to have Dr. Elliott on the show. Ellen herself is a self-professed data geek. I'm right there with her, but I actually think Dan can probably put us both to shame, and I'm sure we'll get into that.
Yeah, so I can, after I read your intro, Dan, everybody will understand why you can put us to shame, both of us in our data geeks category. So everybody get ready, because this is one heck of a bio here. So Dr. Elliott is currently the Chief Medical Officer of Delaware First, where he is responsible for population health activities, which include care coordination, care management, and long-term support services, utilization management, quality, behavioral health, pharmacy, and dental.
Is that all?
Yeah, right? And next year it will
What
be...
services are not covered?
Oh, there's a lot.
No, there you go.
There's a lot. We got a great team that covers a lot of bases.
Yes. And next week it'll be a year for Dan in this role.
That's right.
But it was prior to this when we had the honor of meeting Dan and getting to work with Dan. At the time, he was the medical director of eBright ACO and Christiana Care Quality Partners. He wore many hats during his tenure at Christiana, including Associate Chair for Research and Scholarly Activity in the Christiana Care Department of Medicine. He was the project co-director and director of Evaluation for Bridging the Divides, a project funded by the Center for Medicare and Medicaid Innovation, aka CMMI, one of our favorite acronyms, to develop care management services supported by information technology to improve the quality and cost of care for patients following coronary revascularization. Yes, I said that correctly, and I did not practice. Yes. He is a man after my own heart with a degree in economics. Thank you very much. But his dual major is in political sciences. Mine only in finance. So again, the fact that you have such varying degrees is impressive. And he's also a medical doctor. So he went on to earn his medical degree while contemplating an MBA. He completed his residency in internal medicine and pediatrics at Christiana, along with what is now Nemours. During residency, he served as chief resident. And as if that wasn't enough studying, he subsequently completed a fellowship in the Generalist Scholars, where he earned a master's degree in clinical epidemiology with a focus on outcomes research. This is where we get into the data part at UPenn. While that was interesting, he knew he didn't want his life's work to be grant writing, but instead wanted to use data to have an impact. Luckily, his primary research mentor at the time, Ron Caron, now CMO at CHOP, helped him learn how to use EMR data for applied purposes. He was also given a fairly rare opportunity to spend time, I liked how you said this, quote unquote, figuring it out.
That's right.
Oh, I hit the microphone. This is going to be,
Penalty.
I'm going to do this. There's like a penalty. And worked through he used that opportunity to work through every data source he could find: operations, financial, contracting, EMR, clinical, quality, co-payment elimination with Mark Frederick, and disease management. He has written papers and grants. He has been published. was awarded, I warned you guys, this was one heck of a background. He was awarded CMS Innovation Awards, but ultimately knew he wanted to be operational. And until this new role, Dan cared for patients as both a primary care physician and hospitalist in Wilmington, Delaware for 20 plus years. Dan happens to be a Delaware kid, where he and his wife live a combined 5 miles from where they grew up. But Dan, you have to tell everyone what your Christiana team gave you as a gift when you left for your new position, because I loved this.
Well, I appreciate the opportunity to be with you guys and to share the story and the history and obviously the things that I've been up to in the past and up to now, and honestly things that you taught me a lot in our time together. So to start with the penalty point for me.
I know.
I'm so sorry.
This is going to be a...
I'm going to keep score.
demerit.
I'm going to start keeping score.
So this is actually I'm pathological. I brought it. Yeah, I thought we'd have.
so excited.
I thought we'd have props. It's going to be hard.
This is awesome.
Yeah.
So I am pathologically addicted to the whiteboard. I don't know if any of you guys share that ailment.
I do like to draw.
I
Yeah, they're all
love
pointing at me.
markers. Even my Delaware First Health team during our first retreat, they said he has some problem with markers. Like I just sort of grab them. I like colors. I like to play. But I've always drawn things.
Can we get the full picture of that?
I'll have to.
Oh, and it's on the eBright. I know that logo so well.
Okay, so for those of you listening, he's holding up a blanket that was a gift that has looks like a bunch of different. So people must have taken pictures of your whiteboard drawings over the years.
We had the best team,
And
right?
then they
were
put
like
them onto a
family.
blanket for you.
That's right.
That's pretty cool.
And Sarah Reynolds, who is one of my faves, and she
And
she
it's a
gave this
fuzzy
to us.
blanket.
It is a cozy blanket.
My daughter would love that blanket.
It's in my office. I occasionally curl up with it when it's one of those days, right? And but it just reminds me. And she when she gave it and the team gave it to me, they said we can't let these drawings go to waste. And I actually learned from people to use these. Sort of, I think in pictures. I think in sort of organizational structures, and it's helpful to put them down on paper and help people sort of connect the dots.
I know nothing about this.
Yeah, right. Exactly. We share that in common, I think. So anyway, that's
What
the
a
gift.
super thoughtful gift.
No,
That
no
is like-
kidding.
Really?
That's spectacular.
Yeah, very special. Very special.
I'm curious about all this statement you made to us while a chief resident. You wanted to learn how to use data to fix healthcare, and you never found anyone who could show you how. So they told you just go do it.
Yeah,
Tell us about that.
It was actually a great story, a great time in my life, and I use it when I reflect back on sort of my journey, and particularly when I counsel other folks. Like I went to medical school on a primary care scholarship through the state of Delaware, so I knew I was committed to coming back to Delaware. And I went through residency. I was, again, I bought hook, line, and sinker. I still do. The value of primary care, the mission of primary care, what that meant, what that looked like. That was my understanding of what a physician was and could be. So when I was going through residency, I was asking all these questions, and I was asking about data and trying to answer, why do we do this? How do we fix things? And I had a hard time sort of understanding how to ask a question, get the data to support it, draw some conclusions, and then kind of move forward. I didn't know how to do it, and I felt like it needed to be done. So I actually give a lot of credit to now CEO at Christiana, Janice Nevin. She was then the chair of family practice, and I was meeting with her as a chief resident, and I was honestly trying to convince her to give me a different job and create a job for me. I've actually never had a job that anybody before me ever really had. So I guess it started early. And I was trying to convince her to sort of create this opportunity for me. And she said, what do you really want to do? And very insightful, made a mark on me. And I said, I just want to learn how to use data and how to fix healthcare. And she said, you should do it. And I'm thinking, got a wife who's taking the semester off from her job to take care of our 2 young kids. I've got a mortgage. I don't know, is this a real thing? Can I really do this? And she said, you should. And between her and our then chair of medicine, Dr. Virginia Collier, they gave me the opportunity to go. And so I spent 2 years at Penn. It was just an amazing time. My wife said, don't go get a real job and then go back to school. So if you want to do it now, right?
Yep.
And so she supported us, or supported me as we went through it. It was amazing. So I learned those things, and then I came back, and Dr. Collier then and the team created space for me at Christiana to go figure it out. And, health services research, applied outcomes research. I mean, this is circa 2007, 2008. Like, really new stuff, quality improvement research, implementation research. Those things weren't even terms that we were using regularly. And I didn't really have a concept for it other than I want to know how to do it. So I'm grateful for the training. I'm grateful for the folks at CHOP and Penn who taught me and gave me the skills I needed. And it was kind of off to the races from there.
That's incredible.
Yeah, that's awesome. So I think I got this right. You met your wife
It's true.
on your first day of preseason
That's right.
as a freshman in high school. And not only are you still married,
Indeed,
but it's
thankfully.
been almost 25 years and you have 4 kids that you homeschool?
Yes. Well,
And
my-
you still live at home?
Yes, that's right. Yeah, no, it's been an incredible journey. I was 13, and my wife was 14. So it was kind of a funny day. We always talk about it. I was waiting for my first day, preseason. I was getting picked up, and this guy pulled in one of those classic Grand Wagoneers with the navy blue with the wood trim. You remember? It's like
we had
iconic-
one of those. Yeah.
Yeah, it's like an iconic truck. And pulled in. I got in on the back right. Didn't know anything. The guy was driving. Turned out to be my brother-in-law. He also lives behind us, by the way, now. So it's not only have we not gone far, but my brother-in-law and sister-in-law and their 4 kids live with us,
That's
sort of behind us. It's
outstanding.
pretty cool. But anyway, my future wife, was in the front seat. And by the one word she said and kind of the scratchy voice and by sort of the back of her right ear that I could see in the side mirror, I was convinced that she was a senior, had to be a senior, right? It ended up being a freshman. We kind of were friends all through high school, started dating right at the very end. And here we are 25 years in June of this year, which is pretty
Wow.
cool.
Congratulations. That's great.
Yeah,
That's
it's been
awesome.
fun.
That's
so-
awesome. I
so-
think you
so
have a
I-
sound effect for that.
Oh,
Let's see if you can remember it. Yes.
wow.
There you go.
That's
job.
great. I love it. Well played. Very well played.
So
So
now let me
wait. I just have to say, I understand that your daughter loves to bake,
Oh,
and so
my.
you don't need to eat now. But I did, and those people that are listening that listen to all of our episodes, we're going to
There
record
are people that
another.
listen to all of our episodes.
Apparently, yeah. I don't know that.
Have
I
you
don't
met
know.
any of them?
All right,
All right,
I don't know. But thank you to those that do. But if you, we have a guest coming on, and so that inspired me to bake. And so I decided to bring some of said baked goods, and so they're sitting on the table. So feel free to partake in the baked goods.
They are incredibly tempting. I understand
yes.
they're cracked brownies.
it's
so
it's
Yes.
good that we can't reach them.
That's exactly
Yes,
right.
you
Had
would, and
T-Rex
you might
arms.
hit the microphone reaching them. So it's just they smell. You can waft the.
So Dan, do you actually have a soccer field in your basement?
We're a big soccer family. We do a lot of things. So yeah, so when we live in the house, we built the house that we live in right now. When I built it, so I left space in the basement and made sure that they sort of moved all the structures to the side. And right around the beginning of, right before COVID, we started the process of finishing out that area. So yeah, so now it's like a 20 by 30 space. It's got turf on the bottom. The walls are all I can kick a soccer ball as hard as you want to against it. It actually doubles as an unbelievable ping pong court. It's like the perfect size and perfect lighting for a giant
pickleball court.
ping pong.
Yeah, but pickleball.
We could do ping.
Oh yeah, you
that's
could
it.
do
I'm
that.
just saying,
Sounds big enough.
30
for
by
pickleball.
yeah,
It's
but the
true.
ceilings aren't that high.
9 foot, which
You
is nice.
understand
in the
his
basement.
demographic, right?
Yeah,
So
that's
he's
exactly
bringing
right.
up pickleball.
Do you have the
That's
wrist
an age
injuries?
neck of the- yeah.
Do you have the wrist and ankle injuries to show that you're a pickleball player?
My shoulders don't work
There you go.
at all.
No, but they didn't work
Orthopedic.
before pickleball.
Yes.
So, but apparently you have the type of gear stash in your garage like I have in mine. So you have skis and snowboards and mountain bikes.
It's a
and,
mess. ATVs, golf clubs, tennis
And you like to
rackets.
garden, I
I
hear?
love to garden. Yeah, I'm a proud fig father now.
You
So
walked
I had
in the
my
door.
first fig.
You walked in the door in the hallway outside of Mainline Studios here, and what did the first thing you said?
I said that's a beautiful paddle leaf fig. Yeah, it's
There's a
gorgeous. I just
paddle leaf
bought one.
fig out in the hallway.
Yeah.
Really?
Yeah.
Like not all.
A giant one.
A giant one. Yeah, it's beautiful.
He's the true Renaissance man. He
You
really
are.
is.
I love it.
Where
I
do
love
you
it.
ski? And
Well,
snowboard?
it's funny. We're mostly Poconos. I used to
Okay.
do more trips out west when I was younger, but with 4 kids.
Yeah, I was going to say 4 kids going to the
You
Rockies
got
is
it.
not.
Not all of us can be right on shooting distance from Breck, right? At times in our
Yes,
life.
I still
So-
have my cabin
Yeah,
there.
oh my goodness.
You know
So-
I love to ski.
So I actually got out this weekend for the first time. I have a new snowboard this year, so I got out on Saturday. We were up there by 7:30 in the Poconos. Crowds got in about 10:30. So
There
we
was
were going.
snow.
We got snow. We had 5
Okay,
inches of fresh
so
powder.
it
so
wasn't
was
just
nice.
dirt. That's
no, it was
awesome.
beautiful. Yeah.
So
Okay.
I have to jump in on because I'm a huge dog person.
Wait, your socks. Am I
I do-
allowed to?
no,
Maybe
yeah,
I'm not
so
supposed to say anything
I have an
yet.
old English bulldog.
I love it. I love
We
it.
can show-
For
but-
the listeners, he's showing us his socks. Apparently, they
His
have
dog,
My-
his dog Ollie is on the socks.
That's-
Oh, they're actually your dog.
Yes.
Oh my goodness.
My sister-in-law, I have to give her credit for she always is great Christmas gifts, and so this one surprised me.
love
But going back to you, and I want to hear about the dog fostering. 200 dogs?
Yeah, it's actually closer to 250. Believe it or not, it was actually an X. It was.
You were just a little bit off.
I know, right?
Nah, it's funny.
200, 250.
It was actually, we lost the count because it was actually truly an exercise in teaching my oldest daughter how to use Excel. So I literally made her keep this Excel spreadsheet, and then her hard drive went corrupt and we lost the numbers. But yeah, we started, it's my oldest daughter, she's 21 now. When she was about 13 or 14, we actually had a dog show up on our back porch, broken leg, a little 1-year-old boxer. And we called him Driveway Dog for a little while because the Driveway Fund went to this dog's surgery that fixed his leg. Beautiful story. Ended up going on to another home, and but that kind of got us started. And since we homeschool, my daughter was more flexible. She ended up having pregnant dogs. She became the Delaware Humane sort of. She created this whole foster structure with Delaware Humane, and we would get pregnant dogs. She would deliver them. She'd farm them all out.
Is she a vet now?
No. She's a jack of all trades.
What's the largest quantity of dogs you had under foster at the same time?
I think one time we had 2 litters. One in the basement, one upstairs, and maybe the litter was 8 and 4, 9 and 5, something like that. So we had a fair number of dogs.
One of our 2 rescues that we have right now, similar story. She was pregnant, and a foster family who has also fostered multiple hundreds of all kinds of animals. They've done mostly dogs, but pigs and just all kinds of things. Built a chicken coop in the garage. But she was pregnant. They fostered. They raised the puppies, and then they adopted all the puppies out and the mom. We took the mom. She's the sweetest dog ever.
Yeah, we have a number in our sort of extended circle of people who have dogs that have been through our house, which is fun. We have 2 foster failures. So one is a tri-paw named Carson. So we're Eagles fans in our house. So it tells you he lost his leg right around the same time that Carson did his ACL. Carson Wentz did his ACL. So I have a dog named Carson, who's wonderful. And then just last year we had our second foster failure. So we have this huge muppet of a dog.
But isn't foster failure, you fell in love with them and didn't want to foster
But I'm just so impressed.
It's not really a
that's
failure.
1%. That's
it's
only a
not.
1% failure rate.
So my oldest daughter is a leader. That's just what she is. She sets the temperature of the room. She
Apple doesn't fall far from the tree.
Oh man. Well, she takes it to another level. But she convinced her 3 younger siblings and her 4 younger cousins who live, again, right behind us, that we're just keeping these dogs and then finding them their home is the right thing to do. And so nobody ever questioned it. And but the one Carson we kept because my son was 12 at the time, and he just bonded with this dog because we did surgery. We had him in the house for a much longer time, and it was a huge gift to him around his 12th birthday. We actually went to Delaware Humane, we were giving him back. Then they announced overhead, Joseph Elliott is going to adopt him, and his face went nuts. It was great. It was super fun.
Dogs are awesome.
Yeah,
dogs are awesome.
I guess
we could have a whole dog.
I've got to ask you how many hours of sleep you get a night. 3-4 hours?
No,
listen, you got going on.
Well, with our kids, if the kids bring them in the house, the kids take care of them.
Okay,
right. So I was very clear. If you play soccer, the kids have been washing their own gear since they were, able to do it. So. My wife's really good about raising responsibility.
Yeah, absolutely. Okay, what do you think, guys? Time to get down to
Healthcare?
business.
Unfortunately.
Time to get down to business in the
back.
Yes, business in
Wait,
the back.
I think there's a sound effect for that.
What?
No. Yes, there it is. The business in the back.
No more fun stuff.
Okay.
All right. So our platform of the podcast, as you know, is discussing things that can affect real change. I'm saying real in air quotes, all caps. Real change in healthcare. Dan has been on a mission to create efficiencies in all areas of the healthcare delivery system and has a great statement: the dire need for the rational use of data. So, Dan, what does that mean? Tell us about that.
Well, it's really interesting. Being trained and sort of coming from that background of sort of real formal understanding about what data is, how you use it. I remember my first day in grad school. Brian Strom was leading the program at that point at Penn, and and he said, the question is, what is the question? And sort of this discipline of how do you ask questions? How do you frame them before you even go into data, before you start thinking about it? And I have a saying actually where I've told a lot of people this over the years, but I really think healthcare will be sort of most impacted by people who are trained in the scholarly use of data, because there's something about learning to ask the question and then going through the whole lifespan where you actually have to figure out what the question is, define ideally a hypothesis or some sort of a priori theory that you're moving forward with, and then actually gather the data, transform it, organize it, do something with it, come to some conclusions analytically, defend it, write it, right? And then have it sort of out in the public space. There's something about that life cycle that really helps you understand. And what I found, because we've kind of grown up through the data boom. I remember being in the early days of Pop Health. We were at a collaborative with a lot of leading health systems, and it was the inaugural Pop Health collaborative. And everyone was sort of bemoaning the lack of data. What are we going to do? What are we going to do? 3 years later, we were sitting in the same rooms, essentially the same people saying, what are we going to do with all this data? Now we have so much, but we can't make sense of it, right? And what do you do with it? And it was almost, you get what you wished for. So I think, honestly, and I think we're getting better. There's a maturity in the industry, but one of the things that I've often heard people do is basically use fancy methods, use new shiny things to kind of absolve them of the basics of data literacy and data integrity, and understanding, like, is this actually a piece of information that's going to solve my problem? And it has two problems, right? One, you end up stalling forever because we don't have data. And I often use the question, like, what data would you need? Like, do you need the $10 million or the $20 million randomized controlled trial for 10 years to get you the information you need, right? We'll never know. What do you think's the best thing? So sometimes having sort of data
it's like
literacy.
the enemy of the good.
That's exactly right. And sometimes sort of I find the view of sort of data literacy and data integrity is actually to, like, let's get off the data beachhead, right? Let's move over to practically what we know to do and do it, because data is not the problem here. And then on the flip side, how do we use the data operationally? Oftentimes people are just expecting more than what it can give. They're asking questions, expecting it to, hey, we're going to predict these completely unpredictable random events. And we think somehow technology is going to allow us to do that. Like, no. How about we use data just to come back and say, here's a process. Are we doing that process? Yes or no? Do we think that process is effective? Yes or no? Some of the very basic sort of applied quality improvement methods, PDSA cycles. A lot of times data becomes an illusion. It becomes a distraction. It becomes so big. And let's take some little bite-sized pieces, often which are right in front of us, organize them well, and then kind of work through the life cycle of what we do with it. And I think that's really where the power is.
So that's like, to me, you've described data discipline, right?
I think so.
The rational use of data is really a discipline around data, so we've had, I feel like every episode now we talk about shiny objects, and to your point, right? I remember, every decade there's another shiny object in healthcare. So value-based care was the shiny object, and before that, Pop Health and quality. We could go back, right? We could all go back.
Pop Health is still shiny, right?
It is. Yes, but you know what I'm saying. And but I think we don't do a good job on these shiny objects of, like, what is it really going to save us? What is it really going to do with us? And we get distracted by it. And so I really like your statement of the ruthless elimination of fancy.
Yes.
Yeah, I want to dive into that.
Yeah, it's such a good, I love these kinds of terms because we get so consultant-y, but then these terms are much more provocative.
It ties in a little bit with your comment a minute ago. The best is the enemy of the good.
Yeah.
Right?
Yeah.
So if you're striving for the best, like you said, the $20 million,
randomized controlled trial or some piece of information that's just unattainable.
Correct, unattainable. So you got to go with what you have. Right?
Yeah, for sure. Now, and I think that's where the fun is. And I think, I always use that as the back end, the ruthless elimination of fancy. The front end is acknowledging the endless fascination with fancy, which is a disease, hopefully a curable disease, right? But it's easy, and particularly in the payer-provider space, it's easy to identify what the problem is. And then it's easy sometimes to say, well, we need this to come in and solve that. And I think, as I've been around healthcare and trying to be super practical and efficient, sometimes it's, you see these Band-Aids come in terms of a vendor or a tool or something. And I can see where it fits, but we're going to spend more time trying to figure out match up the inputs and the outputs, get the pipes to really work together. And we're going to totally miss and take our eye off the ball of really basic operational processes, 30-day readmissions. Obviously, it's something that's been going on forever. There's not probably easy answers there, but the question to ask for me is, are we doing the things on the payer side, on the provider side? Are we sort of meeting the members, patients where they are? Are we engaging and sort of assessing the needs? And a lot of times, I did a lot of data work and sort of fancier stuff to try and find solutions, and you end up finding what you know is what you know. Like, the biggest predictor of future is what's happened before, and if you spend your time on the things with the people who have already declared themselves at a sort of high risk level, focus your energy there and guarantee yourself and your team that you're doing the process you think you're doing 100% of the time, or obviously as close as you can in reality to that. And then you can look for fancy solutions, but otherwise we get distracted.
What do you think our obsession is with the fanciness? Like psychologically.
I have ruffles on my sweater.
Yeah,
I mean,
that's
really,
right,
like
yes.
it's a soft sweater, and it's got ruffles. So I mean, I
Fancy.
think it's like a cultural obsession with And I'm not a fancy. I don't feel like I'm a fancy girl, but
No, I know, but we are obsessed with the fancy. You know what I'm
Yeah.
saying?
Oh,
Like
totally.
we can't take our eye off of it.
Well, healthcare is really, really hard.
Ruffles.
my ruffles.
Yeah. Healthcare is hard, right? If you get down to it, you're trying to deliver, obviously all the things we're trying to deliver, right? For people, and we're trying to do it in a way that keeps the profession happy and allows doctors and other clinicians to be successful and all these things. It's really hard. Sometimes it's a lot more fun to talk about a cool, new, innovative idea and how that's going to really change things. And 3 years, 5 years later, you realize, I guess it really didn't, but you've sort of moved on, and it's harder to have the discipline to slow down, especially honestly, there's a lot of leadership environments that sort of prize the fancy and celebrate the fancy. And if you bring the fancy initiative as opposed to sort of focus on the day in and day out and really reward, I spend a lot of time saying, okay, let's say you have 50 quality metrics to attain. Are you really going to have 50 initiatives? No. You're only allowed to have 3, maybe 5 at the most, right? And hopefully you'll sort of find your way through to impacting the other metrics. But, you've got to stay focused. Otherwise, you have frenzy, right? You're going in multiple directions. Everybody's busy. I think this might lead to burnout, right? Probably somewhere down the road. And it's harder and takes more discipline to say, let's slow down. Let's make sure that we're really learning and growing. And we know the urgency of fires that pop up that make that more difficult, but it's a
We
problem.
don't have patience. Well, Justin and I are, anytime we work, well, you probably witnessed this. We always have this push and pull with each other about not being too intricate in what we measure, right? I'm always like, let's have domains, and then under the domains we'll have 3 measures, and then we have this scorecard, and Justin's like, can we just get to the brass tacks?
I love it.
Do one thing. If we can do one thing right, that's
Well, so how do we need to define the objectives better so that we can be more disciplined to not try to do too much?
Yeah. Well, the real challenge, right? And obviously the elephant in the room is, there's regulatory reports, there's public reporting, there's quality, there's all these things where you can't just stop and say, oh, we have the luxury of taking a couple of years to grow. But I think it actually it's a huge leadership step, right? To say, we're going to focus on these core things and we're going to do these things right. And obviously, depending on where you are in the maturity of your organization, where you are in terms of, your relationships with partners and some of those things, you may be optimizing and able to optimize more. But, if you're newer, if you're younger as an organization, if you're getting things started, you can't do it all, that you want to. So you have to be disciplined. And I think the messaging is super important. You have to be clear. I was trained in the sort of driver diagram classic, let's put the boxes and let's put our structure, process, outcomes measures and really track them. And I think there's discipline to that that's beautiful. And then you strip away some of the complexity so that people can know where they anchor in. And I always say there's people that, I've worked with a lot of different people, doctors, clinicians, nurses, MAs, people in all different, leadership levels. And some people you just say, hey, we're going to go do this. And they run with it. They just get it, right? And they just run with it. You don't have to do anything. You just have to pat, applaud, go. And there's other people, you can have the same conversation. They literally look at you. And it took me a while to realize, because I'm a vision guy and we get it and then we know what to do. I was like, oh, you just need to know where to put your foot on the ladder. Here's your left foot, it goes right here. So it's really interesting as a leader to be able to recognize, you've got to be able to meet people where they are and make the message clear and the operational steps clear. And I think, it's easy to miss those. And if you're too operationally focused, people get lost in the weeds. If you're too vision focused, people just think you're out sort of in never land.
Yeah. That's great discussion. So we always like to ask.
Sorry, we're off script.
No, we're not. No, we're not.
No scripting.
No,
but we
and
do,
anybody who watches this on anybody who watches this on video sees us with our notes. And I just want to be clear that, we tell our guests, we have these scripts just to try and keep us from
keep us on track.
Well, mainly so we actually talk about the topic, because we'd probably just sit
we
and
go down
chit-chat,
too many rabbit holes.
Yeah,
but we did ask you, and we like to ask all of our guests about. Buy the world a Coke moment.
You want to sing that for us?
Could teach the world to sing. Okay, so yours hits our topic today of the rational use of data. I think your statement is wind at the back.
Yeah.
So can you
Yeah, that's
Explain
become
that.
a motto. I mean, I don't know how you buy that, but I just believe it in my heart. Like, I just, I guess it's when I've looked at the people I've worked with, I've worked with just great people, like, all the way through. I've never seen someone, I kind of get laughed at when I say this sometimes, like I've never seen somebody who's just trying to make everybody's day bad, right? And really trying to mess up healthcare, right? Everybody, no matter where they are, is trying to do the best they can. And it's just so challenging to watch, like as a leader, in my role when I was actively seeing patients, as a doctor, as a leader in the practice. And it was just so hard to watch. Like the system is literally like putting up barriers.
Well, so that's, it's funny, like a light bulb just went off for me. I'm sure there's like a sound effect for that.
Ooh.
But wait,
No,
like,
no sound effect.
oh, why?
Try
It
one.
makes it fun.
Wow.
No. All right. There's like some kind of jazz
All right,
thing
I
that I
told
can
you
do.
I was
All
worried
right.
about
All
this.
right. But it makes it so much more
He can't sit
fun.
next to the machine anymore.
Okay.
All right. I'll take the applause.
There
All
we
right.
go.
Okay. So we can, yeah. Okay. No, I just, the light bulb did go off for me of thinking when we were preparing for this podcast with you, we talked about the middle of and I do want you to go back to the
Yeah.
wind piece, but let me just say this. I was thinking about, you've been on the provider side because you worked at Christiana. You were on the delivery side as kind of that business hat.
Mm-hmm.
And then now you're on the payer side. But what I missed in that was the fact that you were also a provider of healthcare as a primary care. So you have like this triple, when we talk about triple aim,
Yeah,
it's
there
like
you
you
go.
have a
Yeah.
triple. It's really interesting. Like I said, the light bulb just went off.
Yeah,
for me.
no, and I love that. I love the experiences I've been able to have. And again, having seen people in all these different settings, like people are trying to do the right thing. I mean, people are burned out because they know what they want to achieve and they're challenged to achieve it.
Yeah.
I used to always use this family circus cartoon at the beginning of all my talks. And it was literally like the mommy telling Billy, like, go make firewood and he literally, does the Billy thing or he goes all the way around. I don't know what generation your demographic is. Okay, good. We're speaking family circus.
Yeah,
now.
I feel like though we're ahead of you. Like you're still like a decade younger. I feel like based on your background, I'm like, nope, we are clearly.
That's
He's just
so
an
funny.
overachiever.
I don't know.
He is.
I don't know.
He's done
Well,
like twice of what we've done.
No,
but he's
hardly.
like
Yeah,
a
we have to get
decade
some
younger.
less accomplished guests on the program.
We really do.
You're too funny. Well, let me tell the Billy story. So it's like Billy's mommy says, like, let's make a fire, right? And Billy does all this stuff and he goes all the way and he has these adventures that Billy always does. And at the end, he has a little stick and he holds it up. He's like, is this good? And I use that example to be like, everybody in their healthcare space, doesn't matter where you're sitting, is Billy. Like he's been given a task and he's been super busy, right? He's running through everything. And of course, sometimes you get distracted because you get distracted, right? Work and whatever else. At the end of the day, like we know that what we're delivering isn't quite up to what we want to be delivering. Very few people in healthcare can say like, I'm super satisfied, across the board with what we're delivering. And I think, that leads to burnout, that leads to all those things that we know, right? And so I use that to say, like, man, if we can just start solving, not the fancy, not the like, even some of the next generation stuff, I'm sort of a little bit boring in terms of like a leadership style. Cause I'm like, let's just look at what are the things you're doing today. And, if it takes you 12 steps today to go one, what will you feel like if it only takes you to go 6 to go 1, right? You literally get half your life back, right? And so if you start looking at like where are our doctors in offices spending time, where are patients sort of getting lost in the system, and you start solving brick by brick, those things, can we make it feel more efficient even as we're starting to pick up steam? And so I've always been very focused on what are those little things. And you talked about value-based care. Like you talk to doctors, obviously it's different now, but even a few years ago, you talking about value-based care. It's like, what are you talking about,
Exactly.
right? We didn't have a heavy managed care presence. We didn't have MA and a lot of those things that sort of mature you into some of those systems and processes.
Exactly.
So you're having this conversation like, well, what do you want me to do? Well, here. And when you start talking about what those things are, it's like, okay, I can or I can't do that, right? When it was abstract, I couldn't react. When it's concrete, now I can react. Can I or can I? Okay, you need me to do 9 things, I can do 2. Right, great. Well, let's start with 2 and see where we go from there. And you find like you can actually build momentum. And then as you're doing that, if you're doing it with discipline, then you start to build muscle. Right. And you start to learn, like we're doing this with our team at Delaware First Health right now, like our behavioral health team. We have a little, a group that we're working together, looking at all of our behavioral health measures. We're doing it with the, EPSDT, maternal and child health group. And let's look at our measures and what do we know? What are we doing? And what do we need to do? And by and large, the obstacles for measures 1 through 7 are the same for obstacles in measures 8 through 12. So let's solve it in measure 1 and solve it well and learn about it. And then we'll sort of work our way
trickle-down
through
effect.
with a little bit more accelerated momentum once we kind of built the muscles and we built the teamwork. And it's the commitment to the operational teamwork and the commitment to the vision and being systematic and not letting the frenzy and the fancy get in the way. Because then people just go in 100 directions and you don't have as much to show for it at the end. And that gets back to little Billy with this piece of wood. Like, I don't feel really satisfied, but I know I worked hard. And that's not a good place to be.
What I'm appreciating right now, which it's just so profound, like your descriptors, and it's really like something that it's bringing me back a couple of years, but you like, as someone who loves analogies, like your descriptors actually are like bringing
Getting him all excited.
Oh, good.
No, I know.
He
It's
usually
like really,
uses
We're bald head
sports.
bonding.
I know, but
He usually does sports, but
Yeah,
sports
I-
analogies.
But
Well,
family
whatever.
circus is money.
Oh,
Did we? So what? If Billy brought back a wheelbarrow full of
I mean,
firewood,
that's
would
what
that
we want to be,
Yeah.
right? We want to do it
Yeah,
after
but
a
we
hard
should be
day's
happy
work,
with a
right?
stick.
Yes, I understand.
All right.
And a
So
truck.
you're
truckload.
interrupting Justin. He
so
had like some
He's having an
profound
epiphany.
thoughts
I'm so sorry.
there,
it's
and
not
you-
profound.
I'm
but
so
it
sorry.
was-
All right.
But there's something that a term you've coined, demilitarizing the middle. And this goes between payers and providers and that kind of areas of commonality.
I think it's something I used to think about a lot. There's, I have some funny sort of patient stories. I won't go into all of them, but like as a doctor treating a patient and knowing I want to get them this, like why does it take this whole process to get that to happen, right? And you just realize like I'm the doctor, I had the patient, we had the objective, and it was just hard to get that done for a whole host of reasons. And I just started thinking like, wow, what if we, can figure out how to make those things work well and how to make them aligned. And, I'm a big like Stephen Covey, habit number 4, like think win-win. And, I think that's the fundamentals of value-based care, right? Like there's got to be something here that if we start aligning, start thinking win-win, sure, there's always going to be obstacles. There's always going to be things that are challenging. But I'll bet there's some common ground that we can work towards. And so I think, I like to think, that as we think about that middle ground, I have an order, I have an objective, I have my patient needs, and you work through those processes, we can make sure that the middle, where the payer-provider interface, where all of the subsequent systems, whether it's DME providers and all of the sort of ancillary teams that are required, are sort of starting to work in a way that's aligned through and through. And when you see it, it's like life-giving, right? It's like, oh my gosh, I feel supported. I remember the first time I had a care coordinator, like, and it was like early before everybody talked about it. I had this nurse in my office and we were like symbiotic, like it was like two halves of the same brain. And it was the most rewarding clinical experience like I've ever had because I knew I was supporting her, she was supporting me, we were supporting our patients, and it worked. And when you get glimpses of that in your healthcare experience, whatever it is, it can be around utilization management, it can be around discharge planning. It doesn't have to be sort of right in the front and center, around a doctor-patient relationship. But when you see those things getting more efficient, working to support each other, it's better. I mean, we have a member right now that needed care and special needs patient, had some challenges with the dental system and where do you find them? And so our case managers are like calling and they're sending these emails just like celebrating because they talked to the provider was able to see them, the parents are happy, the kids
worked.
happy. And it's like, so here we are as a payer, but we're like right in there rolling up our sleeves, like jumping for joy that
With-
member and that patient is going to get what they need.
Patient-centeredness
It's unbelievable.
Yes.
at its truest.
That's
Yes.
what it is.
Right?
That's what it is. And it's not the pet you're getting sort of at the sort of the middle. That's not like that the providers in the delivery system are trying to do that and the payers aren't. We're all trying to do that, right? And we're all trying to support it. And those sort of the different tools that we have, the different perspectives we had. I mean, that's why I knew when I was leaving Christiana that I was like, I need to work on the payer side.
Yeah.
And I was advised that by some great mentors who I respect dearly. Now, like, you have to see
You do.
the other system. And I'm so grateful for the experience because I was always told, hey, there's, you have this whole like dark side thing and everything. And,
Yeah.
you get ribbed about it. And you have your own
You've
sort of
gone to the
emotional.
dark side.
Yeah, exactly. You have your own sort of emotional, visceral response to those kind of things, right? But like now that I've seen, I was always told, no, there's really good people over there doing good work. And I've seen it, right? I know it to be true.
You've seen the light.
I've seen it.
Yes.
I know.
And now it's like, how do you get these tectonic plates to like really
Absolutely.
work in
You're
a way
speaking our
that's support? No,
language.
it's so much fun. And you see, and now again, the places where you go wrong with that are saying it's perfect. no, it's not our problem, right? No, it's all of our problem, and it's not perfect. But hey, here's what we can do. Here's what we're working towards. And getting back to data discipline and all those kind of things, it's not fancy. It's getting down to some of the basic things of, hey, we're doing this. We need you to do this. Oh, that doesn't work for you. Do we have options? Oh, guess what? No, we don't right now, but we're working towards them. Great. Honesty, transparency of communication, interaction, and you can start to build something that you can really take into the future.
So you actually just I think shared kind of your aha moment of
It was like it's almost as if this was scripted.
Well,
it was such a
no, but so I can
perfect segue.
I know, but what I was going to say is I think he did share it. So I'm going to ask, now that you have been on both sides, right? The dark side and the light side, and depending on who you're asking, they will tell you they're on the light side.
Yep.
Yeah. It's funny because the three of us have all been on both sides of the equation, and I think
we spent a lot of time doing provider-payer collaborations.
Yeah. And then before we were consultants, because we're not career consultants, we all have had stints on the provider side and on the payer side, on the business before the consulting piece, which I think was really important. But so can you give an example that now that you're on the health plan side, right, that side, can you share now how you see things a little bit differently from when you were just purely on the provider side, both as a provider of care, from a delivery system business owner, as well as a provider?
Yeah, I think first thing, it actually reinforced to me the belief that I've always had, the reason why I went into, medicine and had a primary care scholarship to sort of commit to that path. It's reinforced the importance of a primary care network and a primary care-based delivery system. I mean, you talk fancy stuff, you talk all these kind of things. At the end of the day, we spend a lot of time on the payer side saying our members need to see, clinicians who are excellent, right? And so it hasn't changed my view. It's reaffirmed and reinforced my view of the value of a primary care-based system, of a specialty network that's connected to the primary care team. And it's not, gatekeeper and all kind of those things.
Integration.
It's like the beautiful way that it's supposed to be. And again, you've seen it and tasted it in different places. So, but it's where a member, a patient, needs to see somebody. They need to see an expert. They need to see someone who can really help them. So that's reinforced my value of that. And honestly, it's helped me in the new seat to really see, gosh, what does scarcity of access and limitations of access look like for primary care, for behavioral health? So those things that I knew about, those things that I was familiar with, from the payer side, you just see them from a little bit of a broader perspective. You start to see, well, I have this membership and we need to get them these services, and they either do or don't exist. So how do you now work with collaboration partners? So again, the value of sort of the delivery system. Payers, at least in our experience and the way we're structured, aren't the delivery system. So we're supporting the delivery system through all the tools that we have, provider incentives, value-based contracts, member incentives, all these things. So really important. I think the other thing that was interesting, you mentioned the CMMI grant, that's turned into an NCQA certified care coordination, care management model, right? So I spent a lot of time with the understanding, and I still think it's important, of sort of a delivery system-based care coordination program. And I think that's key. I think the primary care medical home and all of its sort of permutations and levels of maturity is super important. But there's this role that I now appreciate more for sort of what the broader payer-based care coordination system is, right? And the case management system. And so those things are not, again, these aren't sort of dichotomy, sort of either or, they're both ands, right? And I probably had more of a, this belongs on the provider side kind of mentality.
Oh, I remember. I mean, I remember
did I
because
preach that at you a little
did,
bit?
because we were, no, and I'm not just joking.
Yeah.
Like, I remember you and others that you were working with at the time, you were representative and part of a care management
100%.
delivery system.
Yes.
And you were very passionate that the provider kind of owned that. And it's so
in one of the diagrams on your blanket.
That's right.
Yeah, it is. But it's so great to hear you say, I now understand there's an overlay that
Yes.
these things these things fit together, you know?
Well, because we live in a world. I mean, right now, we started with Medicaid. So, the company I work for started as a Medicaid managed care company in Delaware. The parent company is the largest Medicaid provider, Centene, largest Medicaid provider in the country, largest marketplace, and one of the largest Medicare Advantage, particularly the dual eligible population. So you start working, and thinking about, a group of people that are engaged with and facing a lot of things on a daily basis. And so I do believe, again, in a provider-based care coordination, care management system. I think there has to be maturity there. There has to be proactive care. There has to be assumption of responsibility. But we also spend a lot of time saying, hey, a lot of the members on your list aren't really engaged with you. So do we want our providers and our delivery systems chasing those people all around, or do we want them taking responsibility for the people that are really under their care and engaged? It's a both and, right? But to say that responsibility firmly lies with one or the other, probably not the right answer, because people will fall out of that, particularly people who are not going to have consistent engagement at primary care, people who are not going to be consistently engaged in their health care all abroad, who are disproportionately affected and impacted by health-related social needs or social determinants of health. So you have to have this backstop, and ultimately, the payers serve a function, right? As a managed care company, you're taking, in our case, you have federal and state dollars. You're responsible for it. You're contracted by the state to provide a set of services for a set of members. And by golly, that's what we're going to do, and when we're going to put people in the streets to find people who have been lost, people who are challenged. Does everybody respond and say, oh, thank you for being here? No, right? We know that's not the reality.
No.
But you can see why that's a payer role, right? And then that payer role is, can we move you upstream a little bit, or move you closer to a primary care home where there really is proactive coordinated care, where those concepts are owned, they're not just talked about, and they're financially supported in the appropriate mechanisms, right? But I've really just appreciated the breadth of the spectrum, and frankly, the breadth of the challenge that we face, right? So I think those are probably two things that I knew about, but I know differently.
Well, now you really see how they fit together and how they.
I hope so. I have a vision for it, and I know I have team members who are like, they're all in, right? And they were all in on the provider side. That team that we had there and the team that's still working there, they're all in, right? They're wanting to do the right thing, and our team's all in. So now we got two all in.
Well, now
teams.
you can see how they.
You got it.
Which
You
is awesome.
got it.
Which is
Outstanding.
awesome. So
That's fantastic.
okay, as we wrap up. So sad, but it goes so fast, doesn't
it really does. You guys are so much fun.
Thank you.
It's kind of like a Ferris wheel.
Yes.
Is it? And now we're like coming back down
We
to
are
the
coming back
landing
down.
strip.
Yeah, thank you so much for your time, Dan.
No, we're not done yet.
we're not?
No, we get one more question.
Oh, okay, let's go.
We get the last
I was
question.
thanking him in advance.
No, well that's fine, but we're so
We're not at the bottom of the Ferris wheel yet.
No, we're coming in.
Let's go.
Yes. So we like to always ask, if you could leave a legacy in healthcare, what would it be?
Oh, yeah.
Yeah.
Yeah, see, you
Sorry.
can't leave that one
My
off,
bad.
Dave.
It was right after I sort of finished grad school, and I was working with Christiana, and I remember giving a talk, and I just felt like I needed to give a bio, and I still have the slide actually. I sort of put in the upper corner like my own tagline, and it was making Delaware the best place to be a doctor or a patient. And I've struggled with the and/or, and then doctor, should it be clinician, and all those things. But what it was back then was make Delaware the best place to be a doctor or a patient. And I still believe that, not because, obviously I love Delaware, multi-generation Delawarean, like I'm really committed to this place and to the sort of the way healthcare is delivered there. But every grant I ever wrote said, this is a microcosm of healthcare in the U.S., right? We're not facing any problems that are different. We're just smaller in Delaware. We have some innovative things. We have some things that are lagging behind. We have some, we have all kinds of assets and strengths, just like everybody does. But I really still believe, and it's part of the sort of roll up your sleeves and get it done mentality. And so I've enjoyed the opportunity to really, I think, serve and hopefully leave a legacy positively on the healthcare systems and structures in Delaware on the provider side. And I'm certainly learning still, and I hope positively contributing on now the payer side. And I hope those things sort of, again, there's such a big team, there's so many players, but just to be part of that environment to make a real difference so that, the patients, the members, obviously the ones that we take care of at Delaware First Health, know that, hey, we're getting the things done that we need to. We're solving the intransigent problems. We're fighting the good fight, right? We're doing all those things. We're not making it easier, making light of it. But man, we're solving the problems. When there's a gap, we're finding a way to build it. Housing, behavioral health, we're starting to solve those things at scale. You know, it is a collaborative effort. So anyway, to be part of that still means something to me. And obviously I want to do it in a way that's generalizable, that the rest of the country can learn from it, that we're sort of in the same fight everybody else is, and share our little, I always laugh because we'll be on calls with like Texas and Florida. I'll be like, do you really only have X number of doctors? I'm like, yeah, but think about the opportunity that is, right? You know,
Yes,
and
yes.
it's fun to be able just to wrap your head around a picture of healthcare and know that there's, you know, almost 1 million Delawareans in the mix, right? Who their experience of care and what it looks like at the community level, we can make a real difference in, and that's still pretty impactful to me.
Even after that background, you still have a legacy that it exceeds, like it has the same level of magnitude as what you've already accomplished.
So
Wow,
we're
I
not
appreciate that.
not worthy.
No, we are not worthy.
Hardly.
I
been
can
just-
only
you guys
offer
are
you
too
a
kind.
brownie
Yeah,
for the road and a
crack
mug,
brownie, I will
right? A
take.
mug and a
Yes.
brownie is all I have on offer. Our
It's been
cookies,
so great seeing you again.
It really
Likewise, I
was.
appreciate the opportunity to be with you guys. Yeah,
Yeah,
really,
it's
really
really a
fun.
lot of
Congrats
fun,
on the
so
podcast too.
Thank you.
Thank you.
Thank you. Thank you. Well, thanks again. I'm Ellen Brown.
I'm Dave Pavlik.
I'm Justin Politti. We are the partners at BP2 Health, your best chance for real change.
As you can tell, we could talk about this stuff all day. Drop us a line through our site at bp2health.com. This episode is produced by Mainline Studios,
Our guest,
Westchester,
Westchester, yeah,
Pennsylvania.
our guest studio for the day,
yes.
which is it's been fantastic. If anybody needs to record a podcast in the Wilmington, Philadelphia area, as we have learned, we like being in person with our guests. So thank you for
Very nice.
coming in person.
Yeah. Oh man, it's easy for me. I play soccer here. My kids play soccer here all the time. So
All
it's
right.
not,
Awesome.
not a far ride.
Soccer
All right.
podcast coming up.
All right. All right.
Take care.
Thanks again.